So the next session is on spine, pelvis, and acetabulum. And the first lecture is going to be given by Mr. Kalyan Raman from Middlesbrough in UK, consultant spinal surgeon. And he's going to be talking to us about the principles of management of fractures around the spine. Kalyan, please enlighten us. I've had the pleasure of being an intern with Kalyan while he was doing his MS in CMC Vellore. And then I've had the pleasure of doing my MSc in orthopedic engineering for 2.5 years with Kalyan. He's an entertaining chap, and I hope he's able to entertain you all for the next 10 minutes as well. Kalyan, all yours.
Thank you for the invitation. And can you hear me? Yeah. I'm a consultant spine surgeon in James Cook University Hospital in Middlesbrough, UK. I'm going to just talk to you about the basic and then a little bit on the principles. And I think there's going to be a little overlap myself with Ajay, and so I'm going to skip a few slides so that Ajay can pick a few things. So I'm going to talk about epidemiology, the anatomic distribution mechanism, the pathomechanics and the classification and the initial management, and about some principle of management and spinal cord injury and prognosis. The age distribution for the spinal fractures are two peaks. One is the early peak, 15 to 24, where male is predominant, and the second peak is more than 60, where female is predominant. And in terms of anatomical distribution, 25% of fracture occurs in the cervical spine, and 75% occurs in the thoracic and lumbar region. And in cervical spine, predominantly occurs at two levels. One is the C2 level, 1/3, and the rest occurs in about C6 and C7. And most fatal injury occurs in C0, C1, and C2. The thoracolumbar region, the fractures can be classified into three types: thoracic, thoracolumbar, and lumbar. And the thoracolumbar junction is the commonest fracture, and nearly 50% of the fracture occurs in the thoracolumbar junction, and predominantly 60% in T12, L2 region. And L1 is the commonest, followed by T12. The two most common mode of injury is motor vehicle accidents in developed country and fall from height from developing world. And the rest is sports and gunshot and self-harm and other minor injuries in elderly patients with simple falls. As I mentioned earlier, 50% of fracture occurs in the thoracolumbar region, and there are three factors that contribute to the vulnerability of the thoracolumbar junction. Factor one is that the thoracolumbar region is a junction between the relatively stiff thoracic spine and a more malleable lumbar spine, resulting in increased stress intensity at that level. The second factor is the degree of freedom of movement in the thoracolumbar junction. The thoracic spine is predominantly rotation, and in the lumbar spine is predominantly flexion due to the orientation of the facet joint and the rib cage restriction in the thoracic spine. So again, the thoracolumbar junction is vulnerable. Again, it's a junction between the kyphosis and lordosis, and the thoracolumbar junction has got more vertebra which is less oblique, and so any compression force will transform into compression force. If the vertebra is oblique, then part transform into compression force, part into translation force. So again, thoracolumbar junction is vulnerable for compression fractures. In terms of mechanism of injury, compression, distraction, flexion, extension, rotation are responsible for this injury. The most relevant forces are the axial compression, the flexion, distraction, the hyperextension, rotation, and shear. Ferguson and Allen did a classification based on the mechanism of injury, and they were compression flexion, distraction flexion, lateral flexion, vertical compression, and distraction extension, and minor isolated injury. And you just missed one: direct impact is very less common in spine. And this classification doesn't have any prognostic or treatment value, but he believed, Ferguson believed, that understanding this is important to how to treat them. Spinal instability. The definition and understanding of spinal column instability is not clear-cut. And the American Academy defined instability as abnormal response to applied load characterized by movement in the motion segment beyond normal constraint. However, the White and Punjabi classification is a better way of defining it. It says the loss of ability of the spine under physiological load to maintain a relationship between vertebra in such a way that neither damage or a subsequent irritation to the spinal cord. In addition, no development of incapacitating deformity or pain. This definition takes into account of both the neurological and mechanical instability, and also takes the immediate and future instability into account while defining in spinal instability. The two-column theory, which all of you know, is proposed by Kelly and Whiteside, and they divide the spinal column into two columns. One is the anterior vertebral body and the disc, and the rest is the posterior complex of pedicle, facet joints, and spinous process. This is quite important in practical sense. I've never seen a fracture being unstable unless you have broken the pedicle or the facet joint. However, damage is the anterior half of the anterior part of the vertebral body. And here he used this model, says in flexion, the anterior column failed and the posterior column stretches, and in extension, the posterior column compresses and the anterior column stretches. Then Dennis developed the three-column theory, where he divided the vertebral body anterior 50%, posterior 50%, and the posterior element. And he defined the middle column as the most important for stability, and more than two-column or three-column is said as an unstable fracture. However, there are gray. This is a gray definition, and I think not all two-column fractures are unstable. Moving on to classification. It's not progressing. Yeah. There are various classifications, and we're going to touch basically the three modern classifications which still practically used. First is the Dennis classification, where the wedge compression, where only the anterior column is involved, the bus fracture, where the anterior and posterior column is involved, anterior and middle column is involved, and the posterior column could distract, and flexion distraction, where it's predominantly distraction to the posterior and middle column, and compression to the anterior column, and fracture dislocation. Mcafee divided this bus fracture into two, a stable and unstable fracture. However, we know that majority of bus fracture could be treated non-surgically. And the AO classification, they use the A is compression, B is distraction, and C is any rotation and translation. And as they progress, the more is the neurological injury, and more is the instability. And the compression fracture could be just divided into impaction, splitting, and burst. And similarly, the distraction is predominantly could be bony, ligamentous, or anterior extension type of injury. And translation could be forward, lateral, and rotation. However, determination of degree of instability is controversial and difficult, and this has resulted in discrepancy in fracture treatment in between many centers. And the most common is the wedge compression is stable, fracture dislocation unstable. However, there's a gray zone where the bus fracture and fracture distraction injury could be stable or unstable. So the aim of various treatment modality is to prevent further neurological deficit and to maximize the neurological recovery, and to provide appropriate healing environment to result in a painless, stable, optimal functioning spine in the long term. That's the aim of most treatment modality. The initial stage of management, which is evaluation, resuscitation, immobilization, extraction, and transportation, and this is quite very important in spinal fracture. And we should have a high index of suspicion of spinal fracture if there is any pain, tenderness, or deformity at the spine, is any soft tissue bruise in the neck or the trunk, is any neurological deficit, in multiple injury, in high energy trauma, and also in any unconscious patient or intoxicated patient. We always assume there's a spinal injury unless otherwise proven. And avoid chin lift method in securing the airway when you're doing the earlier evaluation and assessment at the site of injury. In terms of restoration, very important that if you have patient has got a spinal cord injury, any hypotension or hypoxia can worsen the prognosis of recovery. So adequate oxygenation and sufficient circulation need to be maintained from the site of injury and till the definite treatment has been started. And inline manual cervical mobilization should be maintained during most of any of the earlier treatment been undertaken. So in terms of immobilization, inline manual traction, spinal board, hard cervical collar, and use side support and strapping, and use an occipital pad for the adults, and use an occipital recess for the children, because the head is quite large in the children, so you should use an occipital recess, so otherwise the cervical spine go on flexion. Always have a high index of suspicion for multi-level spinal fracture, and the incidence is about 6 to 15%, common in high energy injury, and also in elderly population in low energy injury. Again, there could be multi-level spinal injuries.
Kalyan, your time is up. Would you mind wrapping up?
Okay. So the fracture could be non-continuous or continuous, and also look for associated non-spinal injuries. Again, the associated non-spinal injuries are high in high energy injuries, and head injury is very common in cervical spine, and the extremity injuries are more common in lumbar spine, and chest and rib injury is more common in thoracic spine. Always look for sternal fracture when you are assessing thoracic fracture, as they form the fourth column. And abdominal injuries are more common in thoracolumbar, and particularly in flexion distraction injury, you can have mesenteric tear and abdomen and liver and spleen laceration. Neurological deficits are present in at least 10 to 20% of the hospitalized patient, and they are the major indicator of fracture instability and play a key role in the management. Okay, imaging, X-ray is the backbone, and lateral cervical spine X-ray in the trauma series, and do other X-rays if you suspect fracture in the thoracic and the lumbar spine, and we use special views like Zimmer view and oblique view and dynamic view as required. And adequacy of the X-rays and bony abnormalities and disc space and soft tissue shadows need to be looked at. CT scans are quite useful, and particularly in unconscious and intoxicated patients, and also in the cervical, thoracic, and in the occipital cervical region. Because can I have 5 minutes here? Beware of spinal cord injury without radiological abnormalities, more common in children. And in evaluation of an unconscious and sedated patient, look for the component of withdrawal response, presence of deep tendon reflex, long tract sign, and detailed rectal examination, and they may give some clue whether spinal injuries are present or not. You want to stop? Yeah.
You can just wrap up your last slide for the principles.
Okay. Okay, the principal factors that guide treatment are the neurological status of the patient and the stability of the spinal column. And the other factors that influence decision making are the general medical conditions, age and previous work status, presence of other injuries, need for early mobilization and rehabilitation, and the complaints of the patient and his preference, and the patient's, the surgeon's experience, judgment, and preference of the caring team. So the protocol is immobilize spine, treat the life-threatening injury, diagnose spinal injury. If there's a neurological injury, then look whether there's a role for steroid, which I'll ask Ajay to cover it. And probably if you're stable, then use orthosis or jacket. If you're unstable, look for surgical stabilization.
Okay, I think we'll stop there, Kalyan. Thank you very much indeed. Could I kindly ask all the speakers to kindly keep to time? Thank you very much, Kalyan. Our next speaker is Dr. Ajay Shetty from Ganga Hospital in Coimbatore. He's kindly filling in for Mr. Stuart Tucker, who couldn't make it because of visa issues, and he's going to talk about cervical spine fractures. Ajay, thank you very much.
Good evening. My talk will cover cervical spine fractures. Traumatic injuries to the cervical spine occurs in 2 to 6% of the trauma patients and most commonly affects younger individuals, and 1/3 of these can be associated with spinal cord injuries. The of concern is most importantly is the delay in diagnosis. It's mainly either because of intoxication or a decreased level of consciousness. Patient has got polytrauma, missing the fractures on radiograph or inadequate radiographs. A neurological deficit can be present in 40% of these who have got a delay in diagnosis. The cervical spine injuries can be classified into upper cervical spine injuries, that is the OC1, C2, and the subaxial cervical spine injuries, which is C3 to T1, which the subaxial spine injuries are the more important one, which amounts to 65% of all cervical spine injuries, can be associated with a significant neurological deficit and vertebral artery injury. I'll be talking mainly upon subaxial cervical spine injuries. Coming to the evaluation and emergency management, the primary survey includes A, B, C, D, and E, but of importance is the D, that is disability. You have to look for the neurological involvement, resuscitation, and again do a secondary survey. Neurological assessment includes the assessment of the spinal shock. Neurological injury has to be classified whether it's a complete, incomplete, or a root syndrome, and you have to look for the ASIA score. We do know that the incomplete syndromes could be a central cord syndrome, which affects the central part, the upper limbs more commonly involved than the lower limbs, which has got a good prognosis. The posterior cord syndrome, which is more of a sensory involvement with a poorer prognosis. The anterior cord syndrome, motor involvement with a poorer prognosis. And the brown sequed, which is hemisection with a reasonably good prognosis. Investigation, plain radiographs is the mainstay of investigation. A cross-table lateral view will give you 70 to 79% of diagnosis. AP and open mouth view yields up to 90 to 95%. And CT scan is basically to delineate the bony anatomy and when you suspect a fracture, especially in the upper cervical spine and in the lower cervical spine. MRI is definitely indicated in patient with complete or incomplete neurological deficit or a deterioration of the neurological function, and when you are suspecting a posterior ligamentous complex injury in a patient who has got a doubtful whether it's stable or unstable. When you look at the X-ray, methodological evaluation is a must. You look at A, B, C, D, S. Most importantly is the adequate X-rays are a must. Don't make your decision if you are not able to see up to C7, T1, as you can see in this particular X-rays. Lateral view, you should be able to diagnose it. If you are not able to see T1, still you should not hesitate to ask for a CT scan. Look for the alignment, the anterior vertebral line, the posterior vertebral line, the spinolaminar line, and the spinous process line. They should form a smooth lordotic curve without step-offs. And if there is an abnormal alignment and is disrupted, it indicates that there is some major injury that has happened in the cervical spine. Injuries to watch for, which may think for benign, is basically a flexion teardrop, which is basically a significant hyperflexion and a compression injury and is an unstable injury. It may look benign, but if you look at the radiographs very carefully, if you can see here that the posterior interspinous distance is open, and also the fact that it is an involvement of injuring both anterior and posterior elements. The facet dislocation either could be unilateral or bilateral. It is unilateral when the step-off is less than 25% and is bilateral when the step-off is more than 25%. There are various classification systems. The most commonly used is Allen Ferguson, and the recent is a SLIC classification system. As been mentioned by the previous speaker, it's basically a mechanistic classification, which basically means a compressive flexion means the neck is in flexion and the force is compression. When you mean by distractive flexion, the neck is in flexion where the force is a distractive element. These are the various types of Allen Ferguson's classification. The SLIC classification system take into consideration the fracture morphology, the injury to the discoligamentous complex, and the neurological function. And based on this, if the SLIC score is 1 to 3, you can have a non-operative treatment, and greater than 5, you can have an operative treatment. Coming to the management, the initial treatment is immobilization, but the definitive management depends upon the mechanical stability, the neurological compromise, and the patient factors. A brief about the treatment of patients with spinal cord injury. Start with immobilization, then do the medical stabilization, then align the spine, surgical decompression if there is a proved cord compression, and then go ahead and do the spinal stabilization. The medical stabilization is the key because it's important to maintain the blood pressure. The spine, unlike other organ systems, does not have the capacity to auto-regulate. And if there is a fall in blood pressure, definitely it is going to cause inadequate cord perfusion and affects the outcome. More than steroids, maintaining the blood pressure, maintaining the oxygenation is the key to have a better outcome. Methylprednisolone, as per the NASC's 3 protocol, has been advocated, but recent studies have shown that the study itself is flawed, and many centers worldwide do not recommend now methylprednisolone in a traumatic spinal cord injury. Coming to the spinal alignment is basically indicated in unstable injuries and patients with facetal dislocations. You basically put the patient on a traction, but the patient should be awake, alert, and cooperative, and you should have a serial radiographs. There are various controversies in the management of spinal cord injuries. The timing of surgery is one of them. A recent study by Flexion et al. Has shown that decompression prior to 24 hours is safe and is associated with the improved neurological outcome in at least grade 2 improvement in patients at 6 months follow-up. Coming to the treatment of specific injuries, I'll just basically use the Allen Ferguson classification as a guideline. We have basically the vertical compression injuries, which basically causes a burst type of injury or unplayed fractures. The stage 1 and 2 are stable injuries. The posterior column is normal, hence can be treated conservatively. Whereas stage 3 is basically a burst fracture. The posterior elements are injured and it needs a surgical management. An example wherein a patient had a burst fracture, had a corpectomy with iliac crest graft and a plating. And this is, but you can see, it can also be treated conservatively. But if you see the patient has got a significant kyphosis at that level, his function is good, but we do not know what will happen in the long run, maybe over a period of 5 to 10 years. Coming to the compressive flexion injuries, basically stage 1 and 2 can be treated conservatively. Stage 3 and 5 has got a body fracture along with the posterior elements involved, and it needs surgical management. As I mentioned earlier, a teardrop fracture is one which you have to give a lot of importance. This is the management of a compressive flexion stage 4, which has been treated with the anterior cage with a plate. One more example of a stage 5, which can be treated with the anterior fixation. The biomechanical studies show that it is better to fix them anterior and posterior, but however, clinical experience and a lot of clinical studies have shown that anterior alone is adequate in majority of the situations. Coming to one of the most commonest one which we see is the distractive flexion injuries, which causes the unifacetal and a bifacetal dislocation. The injury starts from the back and then moves forward. The first one is just a sprain, wherein there is a failure of the PSC. As you can see, there is a widening of the interspinous process, which can be treated with a cervical collar immobilization. Whereas a unifacetal dislocation, when there is a translation less than 25%, reduction becomes more difficult. You may have to do a reduction using traction, which should be a patient in an awake patient, gradually increase the weight. Reduction is easier in a bifacetal than a unifacetal dislocation. There are various controversies when to do an MRI when a patient is a cervical facet dislocation, and there is no consensus as per the literature. The importance lies in the fact, if you can see, there is a disc fragment behind the dislocated facet. If the MRI shows a disc, and the chances when you reduce it, it can go back and cause a neurological deficit. But what is recommended, or what we do in our practice, in a patient with no deficit, do an MRI before starting the treatment, and patient with the deficit, you can do an awake traction reduction while waiting for MRI. If you are able to get MRI, like in India, immediately you can get an MRI before planning your traction treatment. Which approach to go? If the patient MRI shows a disc in the canal, always better to go anterior. If the MRI doesn't show a disc description, then the surgeon's preference either to go from anterior or posterior. If you're going from anterior, there are various reduction maneuvers, but you first open up, remove the disc, put the distractor, distract it so that the facet is distracted off, and then give a rotation maneuver. Usually about 90 to 95% of the patient, it can be safely reduced. Example of a unifacetal dislocation fixed with the anterior fusion, a bifacetal dislocation fixed with the anterior fusion with a good outcome. In a patient without a disc, you can also do a lateral mass fixation without many major problems. To conclude, a careful clinical and radiological evaluation is a must. A high index of suspicion is always important in a patient who is polytraumatized. Preventing secondary cord injury, maintaining blood pressure, maintaining oxygenation is the key rather than giving steroids. Failure to identify such injuries can lead to progressive deformity and catastrophic neurological consequences. And most of the lower cervical spine injuries can be treated successfully by an anterior approach. Thank you very much.
Thank you very much, Ajay, for keeping to time as well. We've got 1.5 minutes you save for questions.
Reducing the fracture dislocation.
Yeah.
Keeping the spine in extension or in a neutral.
Basically in a neutral position. Once we remove the disc, we put the interspine into.
Conservative fracture dislocation.
Usually we do not treat them conservatively. We give them traction initially in some degree of flexion, and as it distracts, and then you extend the neck.
How do you monitor that? You take,
In our practice, usually we prefer to take into the theater and do the anterior discectomy and you fuse it. We do not, if you want to do it conservatively, ideally it should be continuously done every half an hour increase in weight. It should not be done patient kept in the ward, either in the ICU or a post-operative ward where you get an access to get a. Yeah, if it's possible for you to use a fluoroscope, you can reduce it much earlier. In our practice, we take them to the theater immediately, remove the disc, and do the fusion at the same time.
Okay, thanks. Ajay, could you crack on with your second talk as well on thoracic and lumbar spine fractures?
As mentioned earlier, the thoracic and lumbar spine fractures are considered together because of the similar biomechanics. The thoracic spine is between T1 to T10, and thoracolumbar is between T11 to L1. Neurological deficit can happen in about 20%. As mentioned by my previous speaker, the transition zone is the thoracolumbar junction between the immobile to a mobile spine, between a kyphotic to a lordotic spine, and the orientation of the facet joint changes leads to an increased torsional stiffness, and hence thoracolumbar junction is more common as injury. Apart from the classical ABCDE, what is important is to prevent the second accident while you are transferring the patient from the trolley to the X-ray table or X-ray table to the CT table. Complete, and you have to evaluate whether the patient has got a complete or incomplete neurological injury, and also beware of 3 to 5% of the patient has got spinal injury at the other levels. You should remember that thoracolumbar injuries are thoracic and thoracolumbar injuries are high energy injuries, and 20% of these patients can have injuries either to the chest, abdomen, lips, and head and neck. The priority is to preserve life and then think of the specific organs. As you can see in this picture, the patient with a thoracic fracture can have a rib fracture with a hemothorax. The second one is quite dramatic. We will be more interested in looking at the thoracolumbar junction, but if you see patient has got a diaphragmatic rupture where the gastric contents has moved into the chest wall, which caused significant respiratory disability to the patient, which needed diaphragmatic hernia repair before you can think of a fractured spine. Don't always fall for the obvious. X-ray is the most important injury investigation, because about 80 to 90% of the fractures can be diagnosed on X-ray. CT scan gives a better picture of the fracture. You can look at canal compromise, you can look at the posterior elements. MRI is probably not that specific in the thoracolumbar junction, but definitely is indicated when the patient has got a progressive deficit or when the neurological level does not correspond with the recognized injury. That means to say if the patient has got a fracture at T10, but his neurological level is T6, then definitely you have to get an MRI scan done. This is an example which highlights the fact, like when you look at the X-ray, it looks like a benign injury, but when you look at the CT scan, you know it's a distraction injury. There is a facetal dislocation, there is injury of the posterior elements, it's an unstable injury. The MRI, not only the fact that you can look at the fracture, you can look at the disc, but also you can do a whole spine screening. As you can see here, you can identify the fracture which is present at the other level of the spine. There are various classification systems. Of importance is the Mcafee classification system and the AO classification system. I'll briefly tell about the AO classification system, because A is a compression injury, B is a distraction injury, and C is a translation injury. As you can see in this picture, it moves from a compression injury is a single column injury, involves only the vertebral body, whereas a distraction injury, the injury comes from back, it involves both the posterior and the anterior column, whereas the translation injury, the injury is significant. Therefore, based on that, A is relatively stable, B and C are unstable injuries. Management, the general care is very important. As I mentioned earlier, aggressive cardiopulmonary support, preventing hypoxia and hypotension is very key. The aim is to have a painless, balanced, stable spine with the optimum neurological function and maximum spinal mobility. What is the best method? The question is whether to operate or conserve. What are the factors you need to take into consideration when you see a thoracolumbar fractures? The first important factor you take into consideration is the neurology. Whether the patient has got a normal neurology or a complete or an incomplete neurology. With a patient with a complete or incomplete neurology, we prefer to operate. And patient has got a normal neurology, then you have to look at the fact whether the fracture is stable or unstable. And sometimes the variables like polytrauma to patient, a patient with ankylosing spondylitis, we prefer to operate so that we can get them up and mobilize them much earlier than others. In the patients with a neurology, we prefer to operate because we can gain realignment, we can give stability, we can decompress the cord, we can give a chance for recovery of the cord function, even though it's controversial, and it helps in rehabilitation. The question is, in the patient without neurological injury, how to assess stability. The three things we need to take into consideration is the column concept, either it's a 2 or the 3 column concept. We have got various classification systems. As I mentioned, the AO classification system, the A is relatively stable, B and C are unstable injuries. And we have got the White and Punjabi checklist, wherein they give scores for various parts of the vertebra that is involved, and also the neurological deficit, and scoring them, you score more than 5, you know it's an unstable injury. You know the Halsworth 2 column and the Dennis 3 column, but nowadays we prefer to have more of a 2 column concept. If one column is injured, it's a stable injury. If both columns are injured, it's an unstable injury, but there is a gray zone in between in some situations. Whereas in the thoracic injury, we have to remember the Burke's concept, that is the rib cage forms the fourth column in a thoracic spinal injury. Based on the fracture morphology, if you have got a wedge fracture, it can be treated conservatively. Bony chance fractures can also be treated conservatively if the gap between the bony elements is less than 1 centimeters. We need to do surgery in a ligamentous chance, and any extension distraction, any type C injury, whether there is a fracture dislocation, we definitely need to operate. The gray zone always has been the burst fractures. In patients with burst fractures, we have to look for evidence of the posterior column involvement. The posterior column or the posterior ligamentous complex, which includes the interspinous, supraspinous, the fascial capsule, and the ligamentum flavum. And if it is involved, it becomes an unstable injury. There is a direct evidence. When you look at this X-ray, if the interspinous distance is widened, it's a direct evidence. Along with the burst fracture, there is an opening of the posterior structure. Or by looking at an MRI, you can look for hyperintense PLC. Or what we usually look for is indirect evidence. That is, when you look at a plain X-ray and a CT, how will you know that the posterior column is involved? You look at whenever there is a vertical compression of the vertebral body is greater than 50%, whenever the angular deformity is greater than 20 degrees, whenever on a CT scan at L1 the canal compromise is greater than 50%, is probably the posterior column is injured. And there is a multiple continuous burst fractures, is probably the posterior column is injured. Surgery is preferred in these situations. You can also treat them conservatively if you are able to monitor them regular basis. If there is a doubt in these situations, what is now being used most often is taking weight-bearing radiographs or supine radiographs. It basically used in patients with a burst fractures with a normal neurology when there is a doubt whether the posterior column is involved or not. After a few days when the patient is comfortable, make him sit and stand and then take your radiographs and see the change in kyphus angle and see the change in the interspinous distance. If it becomes significantly more or more than around 10 degrees, it indicates that the posterior column is involved. Coming to the non-operative management, the key is nowadays probably bracing, ambulate the patient, take periodic X-rays, and usually in majority of the stable fractures, it gives good clinical outcome. Surgery, what time? Early surgery is better, but not immediate. Decompression within 6 hours, there is no advantage has been established in humans apart from the dog study by Delma Matter. Be sure to have a stable patient before even thinking of stabilizing the spine. Coming to the surgical treatment, whether to go for posterior, anterior, or a combined treatment, the anterior stabilization, you get a better canal clearance, better kyphosis correction, and better reconstruction of the anterior column. But however, it's a technically demanding procedure and should be delayed until the patient is stable, probably reserved for cases with severe combination of the body. The indications as such for anterior surgery would be a burst fracture with incomplete injury to the cord, significant canal compromise, significant kyphosis, and late presentation. Posterior surgery, the canal clearance is indirect and incomplete. The kyphosis correction could be good, but however, because there is no reconstruction of the anterior column, it can lead to unsatisfactory late kyphosis. It's technically easier and there is a low morbidity. The indication for posterior surgery would be all other fractures. If the patient has got a complete neurological injury, fracture dislocations, displaced lamina causing a cord compression, polytrauma situations, we all tend to do a posterior injury. And usually in majority of this situation, the posterior injury is a long column fixation that is 2 above and 2 below the fracture site. Because we do know that when you do a short column fixation, it can fail because of the cantilever effect, which may lead to high rates of failure. Therefore, in burst fracture, McCormack and Gaines came out with the load-sharing classification, wherein they took into account the combination, apposition of the fragment, and deformity correction, and score of less than 6, just you can treat it by posterior surgery alone, and score of greater than 7 needs anterior surgery also. But what we have found in your practice is that inclusion of screw into the fracture vertebral body improves the biomechanical stability of the construct, and it prevents implant failures. This is one of the patients with a low-sharing classification of H, but you see at the end of around 3 years follow-up, there is no implant failure, the correction is well maintained. And you can see in the picture that pedicles are always intact. It's enough if you put the screw. It's easy for you to put the screw into the fractured pedicle. To conclude, and the recent literature also shows that the posterior approach may be more effective than the anterior approach, but there is no randomized control study to show that. It's also that studies have shown that the neurological recovery does not depend upon canal clearance. The neurological injury has happened at the time of impact, and canal clearance probably does not have any bearing in the neurological outcome, especially when you are operating greater than 6 hours time. To conclude, a majority of the thoracolumbar injuries can be treated conservatively. In the vast majority of the patient, posterior approach alone with short segment fixation is adequate, provided you are able to put the screw into the fractured body. That is for the burst fracture, but however, in patients with fracture dislocations Or a type C type of injury, it's always better to have a long segment that is 2 above and 2 below the fracture site. In patients with extreme comminution of the body and where correction of the kyphosis of greater than 30 degree is required, anterior surgery may also be required. It depends upon the surgeon's preference. It depends upon the center where the surgeon is working. Thank you very much.
Okay, any questions there? Yeah.
Have you got any experience having complete paraplegia at the level of T12 L1 fracture, and you have operated that, there was no sensation before surgery, and after that sensation returns are there and in some improvement?
I mean, we have experience. We have seen patient almost becoming normal following that. But we cannot explain as to why it happens. It's probably a patient's luck and the grace of God.
My question is basically, because patient nowadays they ask what is the prognosis. When there is no sensation, usually the prognosis is the worst. As we say, it is concluded now most of the debates. So can you say to the patient that there are chances of recovery before going for surgery, after seeing MRI?
Nobody can say not based on MRI. I would always say the chance of recovery is maybe 0.1%. If he recovers, he's lucky.
But there are chances.
There are chances, it's just 1.1%.
But
Unstable D12 L1 is the most.
I would prefer to operate, irrespective whether the recovery happens.
I think the
Fracture is unstable, D12 L1 fracture, and unstable, and still there is a complete neurological findings are normal. Neurological patient is normal, patient is poor, patient can take rest for 3 to 4 months. Can you go for conservative?
Not in a type C injury, is probably in a burst fracture.
There is a posterior column, middle column, both are removed.
I would not prefer, it can be done, but there are centers which do that. I would prefer to operate.
Because I have seen that a lot of patients improve with
Yeah,
Excuse me,
definitely,
sir.
yes.
I think
Agree
I'll
to that.
stop it there. I think the concept of this course is to give you principles. I think if you start going into the individual basis of your 100 cases or 300 cases of his,
question is,
yeah.
going for pedicle fixation, do you think it's the final thing or ultimately you have to fuse that?
In our practice, we have not fused a fracture span for more than 10 years. And whenever it's possible, if the patient wants it, we remove the implant. We believe that like any fracture elsewhere in the skeleton, that when the fracture heals, the soft tissues heals, the spinal column becomes stable. It's not necessary to fuse a dorsolumbar spine, and there are a lot of papers, and luckily nowadays, because of industry-driven fact of minimally invasive spine surgery, it has now been more and more papers are coming saying that fusion is not necessary in the spine. We have not fused for more than probably 15 years.
I think can I
Especially in
add
thoracic.
one, Ajay? The main thing is that the most patient, when you see it quite early, they may still be in spinal shock. And spinal shock can sometimes extend more than 48 hours, 7 days also. And if you not seen the bulbar cavernous reflex returning back, or if there's no sensation in the S4, S5 region after 48 hours, then prognosis is bad. Most of the sensation, spinal shock should return by 48 hours. But there is some sensation at S4, S5, and some minimal anal tone, then there is some chance of recovery. So that's the main thing we can tell about recovery. Because a lot of time, you operate a patient in a spinal shock, you have to do it because you don't know whether it's a real neurology or patient spinal shock. And if there is a dislocation or significant compression, we have to go and operate when still they're on spinal shock. And most of the time, the recovery is mainly because they've still been in spinal shock.
I don't know, sensation returns in after 3 weeks.
That is because of spinal shock.
Sensation till 3 weeks.
Yeah, but you have to, the crucial thing according to the Asia impairment scale is that the S4, S5 sensation. If there is some little S4, S5 sensation or little anal tone, then there is chance of recovery.
Okay, thank you very much for that. Staying on the theme of spine, I've got Professor Rajasekharan again kindly filling in for Stuart Tucker, and he's going to talk about principles of management of pediatric spinal fractures.
Thank you, Vikas. I should thank the two previous speakers for making my job easy because they have spoken very well about the principles, and so I would just restrict my talk to how pediatric spine fractures differs from that of an adult. Now, we all know that the child is not a miniature adult. Perhaps in every disease, there is a difference in principle in how we treat children to adults, and the same is also true when you talk of spinal fractures. The spine of a child is more flexible, and hence whenever there is a flexibility, the chance for injury is less. And so spine injuries are relatively very rare in children, forming only 1 to 2% of all fractures. But when it occurs, it indicates a very severe injury, and hence there is a high mortality in children. And the other important thing that differentiates them from adult fractures is, like Ajay said, in the adults, thoracolumbar injuries are very, very common. But pediatric vertebral injuries occur 60 to 80% of the time in the cervical region, when it is only about 30% in that of the adult. Now, the second important difference is that there are horizontal facet joints in the child as it is developing, and hence subluxation is very common. And there is a lot of difference because of the comparative largeness of the head compared to the body. And this is very important because it not only gives more susceptibility for cervical spine injuries because the weight of the head is more, but also because the point of maximal mobility keeps changing during the evolutionary development. So the maximum point of mobility is C2-3 at birth, C3-5 at 8 to 12 years, and C5-6 at 12 years. And this is exactly what happens when the child grows and the susceptibility to injury. So less than 3 years of age, it is upper cervical injuries. When it is 9 years, it is lower cervical and thoracic. And as they become adolescent, they are almost adults, and then the increased propensity of thoracolumbar injury starts. The largeness of the relative large proportion of the head is very important when you talk of immobilization. Now, if you immobilize a cervical spine injury patient in a child in an ordinary board, here you would see that because the occiput is very protuberant, you will find that there is a large flexion force over here, and this can actually increase the subluxation and also give rise to problem. So this is called the SCAT phenomenon. Here you can see, because of the largeness of the skull, just placing the patient on the board actually causes a subluxation over here. So here you need a different proportion. What you need to do is actually have an occipital recess in the board, or at least you should make the body over 2 double mattress for the chest so that there is some provision for the cervical spine to be normal. And this is very, very important in the child. The third difference is the upper cervical spine is full of a region very fertile for anomalies. And here you can see that these are all the various types of anomalies that are possible as they develop. And you should be cognizant of this when you're trying to read an X-ray. Otherwise, you may think that there is a major trauma where there is no trauma. One of the most important things that can confuse you is the Bergman's ossicle. Here you can see that. This is a persistent ossiculum terminal, and because it is higher than the ligaments over here, this is of no clinical consequence. And you should not think that there is a fracture and then go into do something that is not necessary. On the same front, you should not miss an odontoid fracture, which is very difficult to interrupt because of the synchondrosis present here. So how do you differentiate? Now, the facet joint here, the level of the facet joint gives you a clue. If you have a os odontoinum, a congenital abnormality, then it occurs very well high than the facet joint, and the fracture is always at the base of the odontoid, and the synchondrosis, which can mimic a fracture, is always below the facets. So the level of the facet joint is a good guide mark on which you can find out whether it's a congenital anomaly or a fracture or a synchondrosis over here. Now all these evaluations have to be done in a good cervical spine evaluation, and we also need to talk about the Swiss check lines and the atlantoaxial interval and C2, C3 pseudo-subluxation, which are very peculiar for the pediatric spine. So how do you look at the alignment? We all know that you need to look at the anterior vertebral line, the posterior vertebral line, the posterior spinal lamellar line, and the posterior spinous process. Now, this is very good in adults, and if there is even a small disruption here in the adults, it's important. But when you talk of a child, you can get smaller pseudo-subluxations over here because of the flexibility, and you need to be aware of this. So you look at the soft tissue shadows and you look at the stress X-rays to make sure that it is only a pseudo-subluxation. Normally in the adult, again the atlantoaxial interval is only 2 to 3 millimeters, but in the child, space up to 5 millimeters can be present in normally. So you must be aware of this, and you should not think of an abnormality. So when you have a pseudo-subluxation of C2-3, you utilize what is called the Swiss chuck line. Swiss chuck is the name of the radiologist who described this. So more than the anterior, posterior spinal line, here what is more important is the spinal lamellar line you draw over here. And if this is normal, even if you find a disruption in the posterior spinous line, then this does not indicate abnormality. Look carefully for the open mouth view, the odontoid view, because the rotatory subluxation in pediatric age group is very, very common. This is the wink sign when you have a difference between the joint space over here. It's called the wink sign. Look carefully for it. And also, if you suspect, it's important that you look at the distance on either side of the odontoid. If you have a suspicion, just don't hesitate to do a CT scan, which would actually give you a very accurate positioning of these, and you can easily diagnose over here. This is important because if you leave it off like that, if you ignore it, then a few months later the patients may come with such severe progressive rotatory subluxation, which makes it difficult to treat. Then you also have the atlanto-occipital dislocation, which is very common. I mean, not common, but it is more common in children than the adults. The last thing that differentiates the children from adults is the spinal cord injury without any radiological abnormality. First described in 1982, almost unique to children. And what is more important is that many of these children have late deterioration in neurology. They can deteriorate after 48 hours, they can deteriorate after 72 hours. So you have to be very cognizant for this and be very, very careful. A good example is this child doesn't have any radiological abnormality, but MRI does show that there is a cord injury, and this patient had a major problem. Another 6-year-old girl, RTA at 3 years of age, had a SIORA, and you can see that progressively she's also getting neuromuscular spinal deformity. So if you come for thoracolumbar injuries, there is a specific grading and classification which is different. So if you have a chance fracture through the bone, it's type B. But if it involves the lower vertebra end plate, it's type A. And if it involves the vertebral end plate of the superior vertebra, it is type C. And these can easily be, as you can see over here, well treated with minimal intervention, or you can also treat them conservatively. The two other important fractures is you can get an acute pars intra-articular fracture, and if it is acute in the child, it is also very amenable to conservative treatment in a pantaloon cast. So this is quite possible in children. Usually not possible when you talk of the adults. If the patient has a lot of pain and it is persistent, then only it requires surgery, either by these wiring techniques or by the direct Bucks fusion technique, and that is what is required. The last of the specific spinous fracture is the adolescent disc herniation, where a large part of your end plate gets avulsed along with the disc. And this is very common in adults, and you can see. So treatment, majority can be treated by conservative method. Only a very few require surgery, such as in this case, a gross rotatory subluxation, then you require something to be fixed. Or if you have a massive instability like this, then again, these children cannot be treated conservatively, and they require fixation. So in summary, I have talked only the differences between the pediatric and the adult group. A large part of them can be treated conservatively. Beware of SIORA, and they can develop spinal deformities if you don't recognize them properly. Thank you.
Thank you, Raja. Got 30 seconds for questions.
If I understood you well, the SIORA, you can develop, the child can develop symptoms after a few days.
Yeah.
But what's then exactly your indication for an MRI?
Yeah. The situation is like this. So you have a child who presents to you with a lot of clinical symptoms of pain, muscle spasm, and the child cries when you examine, but the radiology does not show any abnormality. The importance is you should suspect SIORA and take an MRI. The MRI would then show whether there is a ligamentous injury, which can be positive in about 30 to 40% of patients in SIORA, Or sometimes there are many reports now which also show frank gross MRI changes of cord without any radiological changes. So what I said was that you should be cognizant of this fact. And if the clinical suspicion is strong, do not hesitate to do an MRI immediately.